Dear friends and colleagues, as active member of Bone Biomaterials and Beyond Academy, I introduce you my first technique. Fibrinogen-induced regeneration sealing technique is a GBR approach that I invented in 2016 and published in 2020. This technique stands out for its simplicity, predictability, and low morbidity. Leonardo da Vinci said, "Simplicity is the ultimate sophistication." He is my mentor, Giuseppe Corrente, who taught me the GBR fibrin sealant based on 1999. This technique changed my professional life forever. At this time, there are few papers about the first because it's a young technique. In particular, I show you this paper of Lofaro, Giacchi, Nanni, and Professor Testori that is an independent paper from me. In May 2024, it's published this book, Building Better Bone by Quintessence Publishing, where the chapter 14 is about the first. And I have the pleasure to present this retrospective clinical study on 105 implants with 3 to 7 year follow-up, published with Kibovics, Meyer, and Professor Mijerisky. As bone tissue engineering triad of Murphy et al., first is a bone tissue engineering triad based on collagenated xenograft, cortical lamina, and fibrin sealant, Genos, T-seal, lamina soft, 0.5 millimeters of thickness. The first key factor is the T-seal. The T-seal contains fibrinogen, that is a regulatory signal. Fibrin sealant is an additional clot that mimics and reinforces the final step of coagulation cascade. In particular, it's very important that this synthetic approtein maintains the natural clot until 10-14 days. The fibrin sealant evidence is this: more than 6,000 papers on general and oral surgery and 600 on GBR maxillofacial surgery, cranial surgery. The main actions of fibrin sealant are hemostatic, sealing, stabilizing, osteoinduction, impermeabilizing. Hemostatic action to be avoided in GBR and GTR because we need blood. Sealing. The plastic surgeons fix skin graft on burned patients without sutures by fibrin sealant. And we have the opportunity to fix connective tissue graft by fibrin sealant. Also, free gingival graft. I place coronal sutures and after some drops of fibrin sealant to fix the tissue graft. Achieving this good result before an horizontal bone augmentation. Stabilizing. Rechtin et al. Demonstrates that T-seal increases the size of the particulate graft for his stabilization, and the fibrin sealant improves also the tensile strength of the graft. In my case, after I learned the technique of my mentor Giuseppe Corrente in 1999, and write the result after 6 months. Osteoinduction. Leinonen et al. Demonstrate ectopic bone in the sheep lumbar muscles. Very important is this paper of Kidway et al. Fibrinogen induces RANX2 activity and osteogenic development from human pluripotent stem cells. Impermeabilizing after polymerization, very important to protect the wound and the sutures. The technique of my master is this: supracrestal bone regeneration around dental implants, achieving a result without membrane with clinical and histological evidence. Key factor 2 of the first is the collagenated porcine bone, GENOS, that contains type 1 collagen that is a regulatory signal and has scaffold action. I remember the first generation xenograph produces at high temperature. High temperature destroys type 1 collagen and ceramizes biomaterials. So the biomaterial is not resorbed after 3 to 11 years. The second generation xenografts are produced at low temperature, so the type 1 collagen is preserved. Low temperature avoids bone ceramization, and avoidance ceramization makes the biomaterial resorbable. The resorbability favors replacement with new bone. Excellent 20-year review is this of Romasco et al. On the effectiveness of bone regeneration procedures with osteobiol collagenate porcine graft. We know that every granule contains 22% of the native collagen. So we have a dual phase xenogenic bone substitute with a mineral phase and collagen phase, with excellent osteoconductive properties and also osteoinductive properties. So by the first, it's possible to achieve a synergistic action of a fibrinogen and type 1 collagen, as demonstrated by Lindsay et al. Induction on mesenchymal stem cells growth and differentiation into osteoblasts. I remember the paper of Jackie, Nanni, and Testori that demonstrates 50% of a new bone by collagenated porcine graft, similar to autologous bone. Key factor number 3 is the cortical lamina that contains collagen type 1 that is a regulatory signal, and it is a biomaterial with scaffold action. The ideal membrane properties, as Cabagé, Serrano et al., are biocompatibility, high tensile strength, space maintenance, permeability to nutrients, growth factor, mesenchymal cells, long-term resorbability, easy handling. In my opinion, it's the cortical lamina. The collagenic porcine cortical lamina, 0.4, 0.6 millimeters of thickness, is a long-term resorbable bone membrane. In the left, you can see a cortical lamina integrated to the new bone, and in the right, a canalicular structure that allows the passage of nutrients, growth factors, and mesenchymal stem cells. Clinical classification system for the treatment of post-retraction ascites of Cardaropoli et al. Class 1 is the only class where we can place a type 1 implant, immediate implant, with bone augmentation in the gap, because we have an intact alveolus, soft tissue integrity, favorable anatomy for immediate implant. But with first, it's possible to place type 1 implant also in the class 3, where we have important bone defect, also total bone loss of buccal bone, for example, soft tissue defect or thin phenotype or inflammation. But we have a favorable anatomy for immediate implant. I present the Lamina Shield that I invented in 2018. I treat dehiscence and fenestration are post-extraction sites. This is the paper where we present a case report of alveolar regeneration. So, we are in 2018. Still no paper in the literature about cortical lamina placed by envelope for the treatment of a compromised post-extraction site. A fistula, this is a class 3 because we have residual bone to receive immediate implant, but with a large dehiscence. I placed a type 1 implant. I performed a full thickness envelope by this tunneling instrument. I placed the cortical lamina dry into the gap between soft tissue and residual bone. Notice, this seems a socket shield. For this reason, I named this technique Lamina Shield. I placed between the cortical lamina and the implant genos mixed with tissue. Immediate loading after the surgery, and this is the result after 5 months, achieving an horizontal gain of 1.5 millimeters. But after 1 year, I achieved this unexpected bony protuberance without pain, inflammation, infection. I don't know the reason of this bony protuberance. Before, after 5 months, and after 1 year. In 2020, we have finally the first paper about the ridge preservation of compromised extraction sockets applying a soft cortical membrane of Fischer et al. Fischer demonstrated an osteoconductive properties of the cortical lamina by appositional osteogenesis. You can see this new bone that protrude under the cortical lamina. And in 2021, we have the second paper, the multi-layer technique of Xu et al. On patients where is missing buccal plate. So it's a class 3. Immediate implant, cortical lamina placed by envelope, connective tissue graft, porcine bone graft into the gap, provisional crown, definitive crown. We are in June 2023. After 5 years, I convinced my patient to remove the bony protuberance. This is a mature bone without soft tissue, no granules. I sent for histology, and Professor Giovanna Iezzi demonstrated cortical lamina. The cortical lamina is present. newly bone formed, and particles. The particles are entirely surrounded by newly formed bone. The cortical lamina is in close contact with the newly formed bone. Unbelievable results after 5 years. The presence of the cortical lamina. I show you this challenge case in aesthetic area. Root resorption of this tooth, class 4, notice the total bone loss of the buccal bone and the loss of 80% of the palatal bone. Total loss, buccal bone, and palatal bone. So it's a vertical defect. This is a vertical defect of my friend Luca de Stavola. And my case, it's very similar. The current guidelines to treatment of similar vertical defect are first surgery, extraction, and natural healing. Second surgery, after some months, vertical ridge augmentation. 3, after X months of healing, the implant. And 4th surgery, implant uncovering and connective tissue graft. So the total surgeries are 4. This is the treatment of a similar case, for example, by Luca de Stavola. I show you my treatment. I remove the tooth. Very easy extraction of a compromised tooth. This is the tunneling action, vestibular and palatal, and I place cortical lamina dry in the vestibular aspect and the palatal aspect. So I achieved a 4-wall alveolus for good containment of genose mixed with tissile. The tissile is very important to seal soft tissue and to impermeabilize the wound. Vestibular lamina, palatal lamina, 4-wall defects. Notice no vertical incision. I not touch papilla. The overgrafting concept. This is the rapid healing after 4 days. And I placed a temporary Maryland. This is the result after 8 months. Note the vestibular volume and palatal volume, hard volume. The CBCT demonstrates D2 quality of the bone. Note, this is 11 millimeters of vertical gain by Lamina Shield technique, before and after. Before and after. The planning got the surgery, I removed the Maryland. Note the soft tissue stability and papilla maintenance. I placed the implant, and this is a connective tissue graft. Notice that I not touch papilla. Very minimally invasive vestibular flap. Palatal incision. The mini flap. The preparation. I place the implant. Excellent stability. I suture a connective tissue graft to the mini vestibular flap. Screw provisional crown. The sutures. After the surgery, after 1 week, after 1 month, after 6 months. Note the new bone peak formation. I remember a periodontal defect. I screwed zirconia ceramic crown. Final result. And this is the result after 4 years. Stability of soft tissue, no marginal bone loss. And the probing demonstrates ischemia, 1 millimeter of probing. So I achieved an excellent result by 2 minimally invasive surgeries. A recent case, central incisor, was compromised. Vestibular probing of 8 millimeters, mesial vestibular probing 12 millimeters, with migration and mobility 2. But it's a class 3 because we have an available bone to receive an immediate implant. I remove the pathological tissue, and my idea was a heterologous dermised lamina because the patient couldn't suspend his anticoagulant therapy. So I avoid to take a connective tissue graft from the palate. So my idea was a cortical lamina glued to dermal matrix by fibrin sealant. Still no paper in the literature at this time. Tunneling action, I not touch the papilla. The cortical lamina glued to the dermal matrix, placed the implant, the dermised lamina, in the gap I place Genos mixed with T-seal. This is the ISQ value. So I performed an immediate load using the natural crown of the patient, screwed natural crown. And this is the result after 1 week. And this is the result after 1 month by a minimally invasive surgery. After surgery, 1 week, 1 month. The CBCT demonstrates thickness by Genos, cortical lamina, and dermal matrix. This is the classification of edentulous jaws of Misch and von Arx. The first is predictable in horizontal defects and in vertical defects up to 4 millimeters. So I use this porcine cortical lamina 0.4, 0.6 millimeters always, but hydrated. The hydrated cortical lamina, if not fixed, detaches for elastic memory. So we have to fix the cortical lamina by tacks, for example, as Wachtel et al., the bone lamina technique. I remember that plastic surgeons fix skin graft on burned patients by TSIL, fibrin sealant, because the full surface adherence eliminates dead spaces. This concept is very, very important. So I use the TSIL to eliminate dead spaces. And after 4 years of clinical application, I published the first in 2020, achieving this result. First, strongly increases the stability of fibrin sealant graft lamina complex. I think that under this collagen membrane, there is no full adherence by sutures. And in this my case, I demonstrate the full adherence that eliminates dead spaces. So the new concepts are simplified stability. The cortical lamina is barrier and bone graft with osteoinductive action by fibrinogen of fibrin sealant and collagen type 1 of collagenate porcine bone, and osteoconductive action by GENOS and cortical lamina. I demonstrate you my clinical experience the long-term resorbable bone barrier when covered. The cortical lamina is present, for example, in this case, after 6 months. And in this case, after 8 months, where you can see the typical canalicular aspect of the cortical lamina at surgery and after 8 months. So we have a long-term resorbable bone barrier. I show my first case of F.I.R.S.T 2016. It's a class B. I placed the implant, hydrated the cortical lamina, GENOS mixed with TSIL, the cortical lamina detached for elastic memory and fixed only by TSIL. And this is the CBCT control after the surgery, the healing, and after 6 months, you can see a new anatomy. Before a concavity and after a convexity. I removed hard tissue for histology with a residual particle newly bone formed and osteoid matrix with new vessels and active osteoblast. This is the control after 3 years. And this is the CBCT 5 years post-op. Note the corticalization. CBCT post-op, CBCT after 5 years. You can see in every cross-section, 1, 2, 3, 4, 5, 6, 7, 8, 9. Before surgery, after 5 years. Another case, horizontal augmentation, we have a class CW, very thin ridge. I modified all the prosthesis to avoid pressure on GBR areas by temporary implant. I remember that woven bone formation is between 2 and 4 weeks, so we have to avoid any pressure during this time. Okay, very, very important. Cortical lamina, genos mixed with T-seal, the cortical lamina glued by T-seal after 1 week, after 2 months, after 1 year. Notice 10 millimeters of thickness of hard consistency. I achieved a horizontal gain of 5.35 millimeters before and after. And I show you the second surgery. No connective tissue, no granules. I take a sample, implant placement, sutures. This is a paper of a slot about the impact of cortical perforation on contiguous donor bone in a guide bone augmentation procedure. In the right, a titanium cylinder with perforations, and on the left, no perforation. This is the histological result. Test group, perforation, you can see new bone. Control group, you can see new bone. In my case, you can see new bone without any bone perforation. The mesenchymal stem cells sources are peripheral, blood, bone marrow, and periosteum. So, the mesenchymal stem cells from peripheral blood and periosteum, thanks to fibrinogen and type 1 collagen that stimulate mesenchymal stem cells growth and differentiation into osteoblasts. This is the histological result with a newly formed trabecular bone where residual particles are entirely surrounded by bone. In medullary spaces are visible small vessels. Free gingival graft. Final result. control after 4 years. No marginal bone loss. This is the one-time cortical lamina, a new technique for horizontal ridge augmentation, a case series published by me and Savio and Rossi in 2021. I remember this consensus of American Academy of Periodontology, wide keratinized mucosa and thickness of the keratinized mucosa, more than 2 millimeters, and more than 2 millimeters of buccal bone in front of the implant. Indication. So, vestibular ridge augmentation, the conditions are sufficient bone for implant, 4 millimeter wide of keratinized mucosa. Key points are lingual incision without papilla involvement, with buccally displaced keratinized mucosa and apically repositioned flap. Implants, exposed healing abutments, and buccally positioned cortical lamina. The advantages are: one, surgery, no re-entry. We have a better blood supply thanks to no flap passivation. Primary intention healing, so no risk of wound dehiscence. A case, a buccal concavity, class B. I place the implant, notice the bone concavity, genos mixed with tissil and vestibular cortical lamina glued by tissil. Healing abutment, 2 weeks, 6 months. I remove the healing abutment and I perform screwed zirconia bridge. Notice a convexity. The implants, and notice the bone augmentation achieved by a simple, predictable technique. Before we have a concavity and after we have a convexity. And this is the control after 5 years. No marginal bone loss after 5 years. Another case of one-time cortical lamina, I performed a suspended provisional prosthesis to avoid pressure on the regeneration area. This is a class B, moderate horizontal defect. This is the surgery. I not touch the papilla of the tooth, implants, healing abutments, genos mixed with tissil in the distal implant. I glue a cortical lamina on the vestibular aspect, genos tissil in the mesial implants, and I reinforce the cortical lamina with a second cortical lamina for a better thickness. So I glue a collagen membrane on anterior implants. Sutures. The provisional without pressure on the regenerated area. Collagen membrane on anterior implants. Double cortical lamina on distal implant. Suture, no pressure. And this is the first intention healing around the healing abutment after 2 weeks. Result after 2 months, hard volume, and after 6 months, I removed the healing abutment, screwed zirconia bridge. The measurements. Concavity, convexity, and disease results after 5 years. In the left, you can see the double lamina on anterior implant, a collagen membrane. Notice the maintenance of surgical volume compared to the site where I placed the collagen membrane. So we have a split site clinical evidence on excellent result of cortical lamina before and after. Disease result, main horizontal gain of 3.4 millimeters and buccal ridge thickness of 2.6 millimeters, more than 2 millimeters recommended in the literature. But the first is predictable also in high vertical defects when bone peaks are within 12 millimeters. A case 11 millimeters between bone peaks, 12 millimeters vertical defect, first quadrant, second quadrant, with an implant out of the bone. This is a case of my friend Luca De Stavola. Similar, my case. I have vestibular flap and palatal flap. The flap passation. Notice the old implant out of the bone. I remove it. Notice the bud axis. The large vertical defect. I glue the cortical lamina to the palatal mucosa. I perform the perforation. Genos mixed with Tissile in the gap. And in the palatal perforation, pressure for 1 minute. Notice the palatal mucosa glued to the cortical lamina, only Genos mixed with Tissile because it's an horizontal augmentation in the second quadrant. So I take autologous bone chips, mixed with Genos and Tissile. I place the mix on the vertical defect. And the last layer is only Genos mixed with Tissile. And I stabilize the cortical lamina 1 minute, no tacks, no screw, suture. After 2 weeks, remove the sutures. Notice the stabilization of the graft. Also on CBCT. And after 1 month, the patient can use a provisional. Result after the month. Horizontal volume achieved before surgery, and this is the result after the month, the same volume of the surgery. The vertical augmentation achieved. This is the planning of my colleague sent me the patient. First quadrant and second quadrant. I can show only this selfie of the patient because she lives in another country. Another case, a vertical defect, high vertical defect with periodontal defect on the canine. Notice, very important, this hard cortical bone, the mesenchymal stem cells are only here. Perforation, implant placement, genostic seal, cortical lamina glued by fibrin sealant sutures. I show you the surgery. Genos mixed with T-seal. Notice the elastic memory of hydrated cortical lamina. So we have to fix the cortical lamina by tacks or by fibrin sealant. Horizontal mattress sutures. And this is the result after 6 months. The second surgery is minimally invasive because I not have to remove anything. No titanium mesh, no PTFE membrane, no screw, only partial thickness flap without touching papilla. Healing abutment, and this is the definitive zirconia bridge after 3 months. Notice the new bone peak where there was a periodontal defect together with high vertical defect. 2 years control. Notice soft tissue creeping. The measurements demonstrate a vertical gain of 7 millimeters. I remember here there is not any mesenchymal stem cell. Before and after. And notice after 2 years, the cortical lamina. The cortical lamina is always present, so we have a long-term resorbable bone barrier. And after 5 years, note more creeping, no marginal bone loss, more creeping. Before, after prosthetic restoration, 2 year creeping, 5 year more creeping. I show you the last case. This is a compromised tooth. I have 8 millimeters of vertical defect in the middle. The bone peaks are 20 millimeters distant. Periosteum incision, flap passivation by brushing, implant placement, Genosity seal, cortical lamina glued by the seal. The implants have tenting effect. So the first is predictable. After 6 months, perform the second surgery, the cortical lamina attached to the soft tissue and to the bone. This is the result after surgery, after 3 weeks, screwed zirconia bridge. Note, I achieved 8 millimeters of vertical gain before surgery, after 8 months, before and after. The conclusions are the triad of F.I.R.S.T stabilizes and maintains longer the life of the clot, has inductive action of new formation of hard soft tissue, protects the wounds, favoring faster healing of soft tissue, has positive impact on handling and adaptation by materials, easily mobilizes CTG bone graft membrane cortical lamina, is predictable in horizontal defect and 2-4 millimeters vertical defect through a low morbidity procedure. Thank you so much, friends and colleagues, for the kind attention.